Thanks,
I think that's a good idea.
You gave that up too freely.
Yeah, I think Pete should do
Okay.
it.
Okay, Pete?
Yep. You need me to move?
Yes, please.
You're going to have to walk me through this.
So you know
no
who you
problems.
are.
No problems. We're here. Okay. Thank you. So,
All
Pete
right.
Piazza, thank you very much. Appreciate it.
You're welcome. Do I need to go
Thanks,
through the... Yeah, thanks, Jody. Remember, I have a year to remember this. If it ever happens again, right. Do I need to read through the public participation guidelines?
It may be helpful because the next one is the public comments.
Sure,
That's
great.
it.
So I'll go through these real quick then. Public participation guidelines. The committee as an advisory committee to the Ohio Board of Nursing follows Robert's Rules of Order, 11th edition, in the conduct of its meetings unless a policy or a guideline is adopted that allows for a variance. Read everything.
You know, the main thing is the public participation.
Okay.
We got here about the public
Perfect.
members speaking.
Yeah.
Mhm.
So in order that committees' meetings may be orderly and serve the purposes of the committee, we just want to remind members of the public they may be heard on matters on the agenda, may make comments, or may ask questions of the committee by requesting permission of the chair during the public comments portion of the meeting. Commentators will be limited to 5 minutes unless the chair moves to decrease or extend the time period and the committee approves this motion. Clapping, shouting, and other such demonstrations and speaking out of turn are counterproductive and will not be tolerated. There are forms, if anyone hasn't filled one out and would like to make a public comment, they're at the end of the table, along with the guidelines. Great. So with that, yeah, we have, Salary Sandy.
Before we move forward, I didn't see an approval of the minutes. I didn't know if that was maybe emailed because I had a comment about the minutes.
Yes, I did too.
There are no minutes. What we have are an official transcript of the meeting proceedings, and they are certified. So those are the recordings of the meeting.
But if there's errors in them, can we not address them?
There's a, I don't know if you found the same one I did.
Well, mine are, well, I'm waiting for your answer, I'm sorry.
Maybe a clarification on something.
I think you, as chair, can say you can speak to whatever
Okay.
and then we can have those.
Yeah, I think that would be great because I actually had a comment on that as well. Go ahead, Sandy.
Thank you. So on page 10, I just needed clarification if this was the correct word or not. On the second paragraph, it says the board cannot professionally work with a professional trade fraud organization.
Yeah.
And I think that was incorrect because I think they were referring to APRN, and it's a professional trade organization, not trade fraud organization.
Understand.
So I would like that corrected.
That was the same one I had noticed, Sandy.
Yeah.
Thank you.
And then, is that, you done? Okay.
Well, the other thing, and I had emailed about this too, that the letter from Bernadette Melnick was kind of, after I reconsidered it, we were given it only as the advisory committee, and it wasn't, it's referred to in these notes, but it wasn't read out loud, so I had requested via email, it may have been to Chantel, and hopefully she forwarded it, to have that read out loud at this meeting. Because I thought it was very important that it was shared,
Do we?
and on record, because it wasn't on record. There's a notation of the letter, but it was not read, and she's such a important nursing leader in the country. It just felt like I think it caught us off guard. It wasn't part of we didn't get it ahead of time, and so, it was kind of informally given at this meeting. And my understanding is she didn't get it to us till close before the meeting.
Do we normally read material that's provided as a document?
It's up to us.
It's any document that the committee has provided, the expectation is the committee members will read it and consider it within the conduct of your business.
Right.
There's nothing as far as that says every information or document received has to be verbatim during the open meeting as if it was.
And it's
And it's made
public
available
knowledge,
too, right?
It's made
Right.
available. So it's not that we're the only ones that saw it, so it's public knowledge?
Right.
Am I correct in that?
Also, she's discussing the transcript of the proceedings. The transcript of the proceedings are the transcript of the proceedings. So if it was not read during, if it was not, read out loud during the meeting, then it was not, and it was not part of.
Right, that's my concern, that it wasn't read out loud.
Read out loud.
But it was considered by the committee at that time.
Right, I think it caught us off guard what to do with that type of information. So I'm requesting today that we read it out loud so it's part of the record.
Okay, can we finish the minutes then too?
Sure.
Okay, so on page 30, Jennifer, it's not Putman, it's Butlin, B-U-T-L-I-N. And then I really want to clarify this so we're not giving the public wrong information. And when I talked about CCNE, which is the Commission on Collegiate Nursing Education, we were talking about preceptors. The standard, which is from the Standards for Accreditation of Baccalaureate and Graduate Nursing Programs, the standard itself, because I didn't have the book with me at that time, basically says 3H, the curriculum includes planned clinical practice experiences that enable students to integrate new knowledge and demonstrate attainment of program outcomes. I'm not going to read the whole thing, but the sentence that I was looking for was clinical practice experiences are provided for student programs, including those with distance educational offerings. Now, and it goes on to elaborate, but CCNE doesn't say how you're going to do that, but there's no reason why the faculty and students cannot work together to get these appropriate clinical experiences. What I did say, which is correct, is that if a program has on their website, we will give you these clinical experiences, then when we come in as site evaluator, you made that comment. Now, how is it that you're following through on that? Otherwise, most people don't do that because you work in collaboration with the students to get these appropriate sites. So they have to, the program has to provide experiences that will allow them to meet the program outcome and their appropriate experiences. I just want that to be clarified since this is coming straight from CCNE and I don't want to give the public wrong information. So that was page 30.
So
and then
Chris,
on 29, on 29 down at the bottom, it says CCME and CCNE, and that's all I had. Thank you.
So your first request for revisions is?
There's no revision.
No,
Right.
I want clarification in these documents
Okay.
so that when you've got all these people reading this, I
Okay.
don't want to make it sound like, hey, we don't have to do anything. That's not the case.
Right.
We have to meet the standards for accreditation.
Okay.
CCNE will not tell you how to do it, but they're going to see the product.
Right.
So they're not into the process, but they're into the product. Is
Result.
the easy way to
Okay.
put
Very
it.
good.
I just want that to be clear. Thank
Excellent.
you.
Thank you. Anyone else? No? All right. So for public comments, we have received 2 requests. We'll ask the first person, Joe Halabaugh, to come up. And I'll see if someone has a time.
She said Jill's in charge of that.
What's the timer?
5 minutes. She'll be right there.
It's no problem whatsoever. Do I hear the ding, or should I just?
Go.
All right, thank you very much for the opportunity to be here today. Again, my name is Joe Hollabaugh, and I represent the Ohio State Association of Nurse Anesthetists. And really what I wanted to do today is follow up on some of the comments that you guys have heard from our president-elect and our government relations chair about legislation that we're soon to be introducing. So Representatives John Cross and Shane Wilkin are joint sponsoring a piece of legislation that's very similar to legislation that we introduced in the last General Assembly, at least the substitute version as we got toward the end, House Bill 191. And I wanted to give you just a brief idea and a basic understanding of the framework of the bill that will be introduced. First, we've had approximately, I would say, 6 to 7 interested party meetings, and we are continuing to try to work on the legislation with everybody that is interested in it, but following several of those meetings in the last General Assembly, one of the major pieces that I know caused a lot of controversy at least was physician supervision. So the draft of legislation that we are starting with in this General Assembly does not remove physician supervision of CRNAs, so that those provisions will remain exactly as they are in current statute. We've also had a very protracted discussion about when CRNAs are implementing any part of what their scope is, and so in this draft we're including the phrase upon consultation with the physician. So all patient care then provided by a CRNA will be with the supervision of the physician, upon consultation with the physician, and then of course consistent with the nurse's education and certification, and in accordance with the rules adopted by the Board of Nursing, which is the beginning of their scope of practice statute as well. So by nature the legislation is permissive, and to get us where we want to be in direct response to the Attorney General's opinion, which has in general restricted the practice of CRNAs in all phases of patient care. The first thing that we do is actually define CRNAs and add them to the list of prescribers. That would be consistent with the other APRNs. However, the language in the legislation also strictly prohibits them from prescribing a drug for use outside of a facility. So it is solely meant to place their ability to order medications related to the administration of anesthesia, not to prescribe medications to be taken, filled at the pharmacy, and taken home. So the basic function then of the bill that we are introducing, and we hope to have that, I believe it will be introduced actually today, so the joint sponsors have filed the legislation, and we expect it to be introduced this week and be numbered and public. The major function of it is to take the existing 4 functions that are in the current scope of practice and add some clarity to them. And so what we mean by that is the existing revised code says, for example, that a CRNA may perform pre-anesthetic preparation and evaluation. And the draft that we have and will be introducing said it explains what that means in a more specific way, to say that a CRNA can perform and document evaluations and assessments, which may include ordering and evaluating 1 or more diagnostic tests and consulting with 1 or more healthcare professional. Establish anesthesia care plans, determine whether planned anesthesia is appropriate, and obtain informed consent for a patient, which we believe makes up exactly what pre-anesthetic preparation and evaluation is. The second function in current statute is that a CRNA may administer anesthesia and perform anesthesia induction maintenance in emergence. That will be retained exactly as it is in current statute, to say that in the immediate presence of a physician, podiatrist or dentist select and administer anesthesia and perform anesthesia induction maintenance in emergence. Also, as necessary for patient management and care, that they can select, order, and administer fluids, treatments, and drugs for conditions related to the administration of anesthesia. Select and order, administer pain relief therapies. The current revised code says that a CRNA may perform post-anesthesia care, so again, we're offering the clarification that they may perform and document post-anesthesia care preparation and evaluation. Also be able to direct registered nurses, licensed practical nurses, and respiratory therapists to provide supportive care as necessary for patient management and care. The current revised code also states that a CRNA may perform clinical functions, so we add some clarity to what the clinical functions are. That language is retained in our draft, that they may perform clinical functions.
Thank you.
That's timer? Okay, yeah.
That is
so
time.
That is the basic outline of what the actual legislation looks like, and I'd be happy to answer any questions. Yes.
I'm just curious, why are you going, probably from a political standpoint would be my guess, but why not collaboration as opposed to this supervision? Is that not, even thought of? Because we're in a collaborative state, so you're talking about under the supervision of a physician. Is it not, are you looking to collaborate with the physician as opposed to being supervised, or is that something that's totally?
No, it's not something that we have directly complicated, because I don't think that we we don't think that most accurately reflects the actual practice of anesthesia. So they're working under the supervision and then being consulted for the anesthesia services, which we're trying to reflect in the legislation.
So you feel that you need that under the supervision as opposed to in collaboration with a
Yes,
physician?
correct. That will be maintained. That's the way the current statute is now. So that would allow, you know, the facilities to be able to.
No, I was thinking of
perform
getting
it, yeah.
away from the supervision and doing collaboration, which is what, you know, we have, is where I was
Yeah.
going with this. We didn't want supervision, we got collaboration.
Yeah.
And I was just wondering why you're not pursuing kind of the same thing that the other
That was part of
APRNs
the
did.
initial draft of legislation that
So
we
that's
introduced
what you
last
had to
year,
go
but as
with.
we're working through
Okay.
the process, we
Okay.
realize that's become a very big sticking point. So
Really?
we're willing to work with,
Yeah, so
we're
they
trying to
don't-
work as hard as we can with everybody to get the best
Baby
policy
steps,
solution.
right?
Good,
Yeah.
good baby steps.
Yeah, good luck.
Thank you.
Excellent. Any other questions?
Thank you.
Thank you. Our next speaker is Jocelyn Greaves.
Hi all. Welcome, Pete,
Thank
to
you.
your new role.
For a hot minute, right?
Okay. Thank you for allowing me, or all of us actually, the ability to speak for a few minutes and just kind of provide some updates. As many of you have probably been aware, House Bill 177 had testimony with Representative Brinkman about 3 weeks ago and presented the bill in the Health Committee. And OAPN is thankful for the support of all of the APRNs who are writing letters, speaking to their legislators, just providing that encouragement to their legislators from their constituents in regards to this House bill. It does make a huge difference for us as we move forward trying to remove the standard care arrangement. It will continue. And as you probably know, we are having proponent testimony tomorrow, which is super exciting for all of us, and the next step as the bill does move forward through Health Committee. So side subject also, as you guys are working on your interpretive guideline and speaking about that a little bit more this morning, stuff from across the street. I have a few comments, and I appreciate that we were able to provide as outsiders comments that we may have in regards to this interpretive guideline. All of you should have received that. I think it did get emailed out, some of our opinions, and so I just kind of wanted to comment and hit on a few of those again. And these more are questions that I have back to you that maybe you can think about that I'm sure other APRNs will have depending on where you guys go with this draft. You probably are all aware, besides there being listed as master's or doctoral trained, what about the ones that are certificates and that didn't really go in to finish the master's and they were grandfathered in? Where, do we need to address those in this guidelines? The definition of critical care is technically a billing definition, and in primary care and outpatient practices, we are seeing some acute conditions, which we know, sinusitis, those kind of things. But what happens if someone that's like an acute MI or someone who's a stroke or someone actually codes in your office? Now I realize those are not things that are common, but will an FNP get in trouble or have issues if they're trying to treat or stabilize that patient? What about patients who are, or FNP certification for emergency rooms? Where does, how is that addressed in this guideline? Because technically they do have to have an FNP to be able to get that emergency room certification. And then what about procedures? And I think Lisa might have hit on this, and so forgive me if you did last time. Do procedures or do not procedures even fit into these guidelines, because those are trainings or certifications that you can take, or is this something that you have a different guideline? So again, please forgive me if you did address that last time. And then what about the patients that are like pediatrics or neonatal that have congenital diseases that they then progress into their adulthood? And so if you look on those graphs, the boxes, they stop at that young adulthood. What about those diseases that typically those pediatrics treat into that adulthood population? How is that addressed, and does that go then outside of those guidelines? So I'm just kind of, these are questions that probably other APRNs are going to have, and so I'm just trying to provide them as things that maybe you can kind of think about as you move forward and working on them. And I know that this is a draft, and again, I appreciate being able to provide comments, and hopefully other people did as well. But those are some of the concerns that I have. And my concern is that questions like these or more will continue to arise over the course of time. And will this cause more confusion by the APRNs and then maybe even potentially hinder patient care? My thought is sometimes simpler might be better. That's it. Thank you. If you have any questions, I'll keep going.
Any questions for Jocelyn?
No, but thank you.
Thanks, guys.
Thank you.
I have a
Oh,
question.
Sandy
Yeah,
has a
sorry.
question.
So it's very interesting about the comment about critical care being a billing code.
Yeah.
I guess my question for OAAPN would be, so does OAAPN, you as president of OAAPN, feel that because it's so specifically a CMS rule that it's inappropriate to use as the guideline here? It's been one of our sticking points for how many years, of the definition of acute care, because the law clearly says that APRNs can take care of acute disease.
Right.
And so trying to put a rule around it has been difficult because of definition.
Yeah, I know that's been one thing you guys have all talked about over the last couple year or 2 years. What is the definition of critical care? And you know, the concern that we have is that if you have this as the definition, it's a billing definition. Outpatient providers bill high complexity, so you might have a patient that has 4 different diagnoses. You know, hypertension, diabetes, and acute angina or whatever, and then you're treating them in an outpatient setting. So if they're bill high complexity or critical care type, you know, then does that come back and now they're dinged because they're billing that high complexity, where they get, you know, you make decent money in the outpatient setting billing at high complexity. So that's kind of the thought we have about that.
So your concern is if they, and they do, and I have level 5, you know, in well visits. So your concern is that then that might reflect as them going beyond scope because of the billing code.
Right.
I see. Okay. Thank you for that.
So, you know, I'll just make a comment regarding
Sure.
the CMS billing. And so while the definition is definitely from CMS billing, we also want to keep in mind World Health Organization also uses a very similar definition to define what is acute care. I know we brought those 2 definitions forward several meetings ago. Just wanted to make that comment.
And these are just thoughts.
Yeah, no, very good
Good
thoughts.
stuff.
Thank you. Thanks, guys.
Thank
Have a
you.
great day.
Thank you.
All right.
Oh,
Oh, sure.
Yeah, you can ask for more if there's more.
Absolutely. Yep.
Thank you.
Thank you.
so much.
Do we have time to?
Mhm. Yeah.
All right. So, Kelly,
Yes, hi again.
how are you? This is
You?
Kelly Dieter.
Hello, Kelly Dieter, Ohio State Association of Nurse Anesthetists. I just wanted to follow up on your question, to kind of give some context regarding the collaboration. Since we work in the immediate presence of our supervising physician, it would be impossible to collaborate with maybe 50 or 100 physicians that may be supervising us at any given time, because it's not just one physician. So we would have to have a standard care agreement with 50 or up to 100 physicians, depending on what, you know, facility we worked in or what models
Unless you
of
have
care.
a chief, chief concern. No, I was leaning towards more of what we fought for
Right.
years. We
Right.
didn't want supervision, we wanted collaboration,
Right.
so
Which
I
requires
was kind of
a
working
standard care
to your
agreement.
side,
Right.
yeah.
But
Yeah.
we would.
Yeah, no, I understand, I
We
understand
work
what
with
you've got.
up to, like I said, it could be 50
Yeah.
to 100 physicians, so
Yeah.
it would be one separate physician that we would be collaborating with rather than a physician we were working
No,
with.
I
So
understand.
there's
It's
just some
just-
things that would be, because there are some states that do have
Yeah.
collaboration of nursing
Right,
anesthetists.
right.
So.
Just a comment too, I mean, I think this is strategic, why
Right.
supervision's
Yeah.
still in there, and I appreciate that, but, you know, the physician assistants have to list everybody, so many of them are surgical, that you will see them with 30, 40, 50
Right.
physicians on their supervisory agreements, so don't let that be a barrier.
Right, but in Ohio, collaboration requires a standard care, so.
Right.
That's kind of.
But it's still.
Yeah, and if you're like running a
even if you had a designated
Yeah,
chief
like a
that
chair.
could sign, or chair,
So,
that could sign for
so the
that, like
collaborator is
we
supposed to be in
can.
your specialty, if I'm not mistaken, correct? That-
Yes.
Like the chair of
So-
Yeah.
anesthesia.
So it would be difficult, I mean,
Like the
the
chair
ER
of
physician
anesthesia, right?
is not an anesthesiologist, so we're not sure how that would play out either. or how
Okay.
it would look.
But thank you for the
Okay.
clarification.
Thank you,
I'm
Kelly.
trying to help you out.
Yeah.
All right. Moving on, next line of business is draft interpretive guidelines, OAAPN comments.
So-
Chris, were you going to say something?
Well, are we gonna talk about the interpretive guidelines and the comments?
Yeah.
That's what I have.
The
Is that
OAAPN
okay?
Yeah,
We talk about-
absolutely.
okay.
That's what we're moving to.
First of all, thank you to the people
Yes.
that are working on these interpretive guidelines, because we know that this is a major task. So I have a number of things that I'd like to go through, if you can please bear with me, okay? So, because I'd like to speak to some of the comments and the documents that we were given for review, and my understanding is they are public. We all know that scope of practice is a legal term. I think Lisa just passed out some other things too. It's based on nationally vetted competencies, formal graduate education, and certification. It can be narrowed by the employee's desires, but it cannot be expanded. So that an adult acute care person, we're not qualified to take care of these pediatric people, or to provide wellness in women's health, or an internal medicine type of a practice. Family psych person isn't qualified to provide primary care for conditions such as pneumonia and hypertension and things along those lines. Peds primary care NP isn't prepared to provide intrapartum care to laboring women, and the list goes on and on and on. There seems to be such a focus on acute care, but we have other issues elsewhere. There's specialization in all fields, and I think a good example of that is if a family physician wants to do neurosurgery, there is no hospital that I would imagine where the Board of Medicine would allow them to, or credential them to do that until they went back for further education and for certification. So that I think we have to keep that piece in mind, because it's a public, it's to protect the public. Now, with respect to fellowships, and you can all go online and read our FAQs. CCNE is in the process of developing standards for accreditation of graduate fellowships. Some places call them residency. That's unfortunate. They're fellowships, okay? They have made it clear, and when our chairs met with NOF, one of the concerns was, is the intent to increase scope of practice? And it was a resounding no. And it's right in their FAQs that the point of developing these standards for accreditation is that CCNE was asked, but it was very clear that the fellowships do not expand their scope of practice, because the education needs to be within the person's scope of practice and certification. I give an example, I don't know when, about if I went out and learned how to deliver babies or do colposcopies. That does not make me a women's health provider, nor does it make me any kind of a midwife. And I know that whole thing was brought up about acute MI. Even in my cardiology office, the treatment would be to call 911. I don't care where you're at. I mean, even the MAs would know how to do CPR. So that was like, but that was one thing. My understanding from at our last NOF meeting, and Lisa probably knows a lot more about this than I do, the Council of State Boards have funded a research study that is going to really query the hospitals and credentialing boards for an understanding of where they're at, because not everybody's got somebody like Sandy on boards who's got a good handle on scope of practice, and we know that's the case not just in Ohio but throughout the United States. So I think to get that information, which I think is not going to come forward for another year or so, is going to be amazing. The whole thing with the emergency room is an issue on a national level. It came up at the LACE meeting at NOF, the Licensure Accreditation Certification Education. It stands for LACE under the APRN consensus model. My understanding is from the national and state boards, and I know Ohio is there, is that it does not increase the scope of practice. I will tell you, it comes up at every meeting. It's an issue. Acute care people cannot take this exam. It's based on portfolios. we have a ways to go. I said before at this meeting that I really think we do a disservice to the people that are working in emergency rooms because it's a specialty in and of itself. So that I just think when we look at all of this, we have to keep in mind that scope of practice is a legal term, and it is on nationally vetted competencies in formal education and certification. And when we're working on this, and there's a lot of gray areas, and one of the things that we had talked about the last time, and maybe I missed it, but on the guideline we had said that we really need to reference primary care scope of practice, women's health. I mean, we need some kind of an arrow or something or asterisk that sends the person back to their scope and standards of practice for the exam that they sat for. I know that we have the references here for the exam, but I think we actually need the scope and standards of practice that have been vetted by all of these organizations, and it's something that's followed through with this whole consensus model. Thank you for listening.
Chris, you're speaking specifically to scope of practice, not the core competencies that you would reference, right?
I would, yeah, it says scope and standards of practice. Ours is a yellow, orange document. Primary care is blue. I mean, there's a whole bunch of them that are out there that are taught in leadership classes that students have to get, graduate students. So I think that would be, because that's what they need to refer to, is that there's scope and standards of practice for peds, acute, primary, neonatal, women's health, and I think we need to definitely reference that in this document. I would refer people back to that. So this is great. This is, we're working on this guideline, and that's just it. It's a guideline. But I think these people need to be aware that, hey, look at your scope and standards of practice, the certification exam that you took, right? Does that make sense?
Yeah. Yes, it does. Thank you.
Thanks.
Sandy?
So, just to hark back to the past 2 years of this has been the problem all along. This kind of oversimplification of scope. Yes, that's scope, but then it's mostly gray areas that we're talking about.
Agreed.
So
Agreed.
This is again the same issue. I'm afraid you're oversimplifying it, Chris. So as we move forward to look at what Gina Singleton has put forward for OAPN and the guidelines that the board laboriously have been working on too. I think we have to keep in mind that we really haven't clarified that. This is all about putting a role on something that there's still a lot of disagreement. I don't disagree about scope, but I disagree about training and what's beyond scope is critical to your practice. And yes, you're absolutely right. I wouldn't go do neurosurgery. We're not talking about those areas. We're talking about the areas that are much harder to define. Surgical procedures. You ask for a privilege. You do your competency. You're doing surgical procedures in an outpatient setting. That happens all the time.
That's not critical care. To me, it's not. Yeah. The FNPs learn IEDs and all that stuff.
Wait, I'm not talking about that. I'm talking simply about scope and how you expand what you are able to do beyond your initial training.
But that is taught in training.
Somewhat.
That's taught in
Depends on
training.
the person's
Well,
training.
I don't think that from an education standpoint, I'd have to agree with Chris, and probably because we're both educators. From an education standpoint, there are many things that people will do within their scope of practice that are not taught in the classroom. So, because you can't teach everything in an academic program, but there are things that are outside of the scope that I think that's where we're coming into that to me, that's where the gray area is not some of the things that are within the scope, but the things that are outside of the scope that people are doing in primary care or acute care, per se. Because there are many, for example, FNPs who are working in acute care settings, which is not a problem, but it's when they're taking care of hemodynamically unstable patients. That is outside of their scope of practice. And when you have acute care nurse practitioners taking care of stable patients in a specialty clinic, in my opinion, that is not outside of their scope of practice. So, I mean, I think there are gray areas, but when I first looked at this chart, it was sort of confusing to me. I wasn't at the last meeting, so boo on me. But I still think that it leads a lot to gray. I'm not sure, and I appreciate all the work that went into it, but, you know, what is orange? What is yellow? You know, it just says usual health and critical, and I'm not sure that it gets rid of enough gray to define where the line is. You know what I mean? The line in the sand.
Do we want to get rid of that gray?
Right.
I mean, I would.
Can't get rid of the gray. It's
No.
always
Right.
Yeah, you can't.
You're not going to be able to get rid of the gray.
But the lines, I mean, we talked about that at the last
Yeah.
meeting, right? You did, that line, you know, it's not a line.
It's
kind
a
of
wavy.
fading or something.
And I think you don't want to get rid of the line.
Yeah.
I mean, you don't want to get rid of the gray, but I don't mean it in a way that it's punishable, but in a way that it's definable and understandable and gives guidance to the practicing APRNs as to exactly, you know, there has to be some sort of wavy line, diagonal line, something that they understand where they're supposed to be in a gray, broad spectrum.
Sure.
I think there needs to be more definition of that.
And one of the challenging pieces, and we alluded to this a couple years ago, was also the evolution in practice as well. So what was once seen as critical care is not necessarily managed by critical care anymore. So that's where it gets, I think, challenging in trying to remove the gray entirely. And Latina brought up when she was here, the perfect example of the transition through the gray is your asthmatic, which may be seen in a primary care clinic all the way through to a critical care setting. So, or you're diabetic. There's lots of examples that I'm not sure you're ever going to be able to remove the gray.
And if we can take the focus too of acute, I mean, because you've got primary peds and you've got psych. I mean, I didn't interview this person, but a relatively new FNP grad who's doing psychotherapy and managing these really complicated psych patients. Now, to me, that's a little bit dicey. I wouldn't want to do that. Unless she's smart enough to come back.
In the ICU,
and
we get all the admissions if they overdose. We get them for the first 24 to 48 hours.
Right.
Looking at other.
But she's doing this constantly, on an outpatient basis. I'm like,
so are we,
okay.
unfortunately.
I have a question for the committee, and maybe it's been discussed before, and I just wasn't a part of the committee at the time. And I think I heard a little bit of this maybe in Sandy, some comments you have made. But have we ever defined what formal education is other than just academic?
Well, I think we haven't, other than what Chris just put forward. But I think in the OAAPN model, so their draft, they try to define it a little more. So I don't know if you've gotten through this. This is a very important document, I think, for this group.
Yeah.
And it's formal graduate education. So how would you define that?
So that's how I have come to understood it.
Right.
But what I am wondering is if we need to define it, because formal education, I hear a lot of folks often refer to, I've had continuing education, I've undergone a fellowship or a residency program.
Well, and as Jody's just said, you can't teach everything in an academic program. You just said it all right there. If you can't teach it all in an academic program and then I get them as the employer, I need to continue to teach them.
Right, within their scope of
Within
practice.
Within their
scope.
scope of practice.
So we agree on that.
So a family practice NP who did training in an express care, who, why couldn't I put them in an ED? If they stop when the patient gets critical, just like you said you would do.
That's fast track, that's appropriate. I think we agree on that.
And
So
then
an
if there's
FNP
no
working
one-
in fast track,
if
that's
they're-
very appropriate.
But no, an ED. If they're in an ED, let's say a rural, let's say a rural ED where, that's a mix. It's not Metro Health CD where we have gunshots and all kinds of things all the time, right? That's critical. We have critical patients all the time in our ED, 350 a day or something we do. So the rural place where there's an FPNP, for sake of argument, we'll say she or he has not had the additional certification in ED. normally they just get run-of-the-mill things that are like Metro Health's Express Care,
Right.
which we actually had a gunshot there once.
So you stabilize the person and
Right.
transport them.
Right,
I mean,
which is
there's no-
typically what
which-
happens in a rural
Right.
ED.
Yeah.
An
So-
acute
I mean, that
patient
would
is
even fall under
transferred.
the Good
correct.
Samaritan Act.
So correct.
So,
Exactly.
yeah, I mean,
So-
I think we all agree on that piece.
I
yeah.
don't get what the argument is.
Well, that's why I wanna take this whole focus off of acute care, because it's a lot of other
expand it,
specialties.
right.
And it's always been acute care, and it's like, wait a minute, there's other issues,
We always
that's
come
going
back
on
to
in the United States. I know.
Ohio law says APRNs can deal with, can manage acute disease and illness. So we are allowed to. Acute, it's in the law. It's in the law.
Says
Yes.
acute illnesses.
Illnesses, right, same thing. It's acute illnesses. What does that mean? Again, it's gray. I think what the board was trying to do with this colorful document was to try and say critical care, which I liked that definition. But now, as I hear from OAPN and read this document, will that cause more problems than we are looking for? I like the fact that the critical care comment means that patient is truly, truly sick. And I think even Chris said, as an acute care NP who works in an outpatient setting, she wouldn't manage that patient either.
You're gonna transfer
Right.
them.
Right.
You're gonna call, my treatment would be 911.
Right.
So it sounds like what's concerning might be those shades of orange that lead up to the red.
Well, I feel also, after I had a chance to review this document, I feel it's, your intention from the board was to be clear, and it's not clear. It's
Yeah.
muddier, I think, and there would have to be too many explanations to make it usable. There's overlap, CNSs, where do they fall? We talked about that a little bit at the last meeting.
I need to be clear, this particular IG, draft IG, is specific to certified nurse practitioners. It does not address CNS scope of practice, nor CNM scope of practice,
Right.
nor CRNA scope of practice. Each one of those APRNs have their own distinct statutory scope of practice.
Right,
So
but-
the application of CNP applies only to this
You want us
IG.
to raise our-
Go right ahead.
Correct, but CNSs function very much like NPs in many, many settings. That is the
Certainly.
modern way to use CNSs, and it is within their scope. They have the didactic training and the clinical training. Many are parallel with NPs in their training, except the systems, when they learn process and systems, that's where they differ. So why are we singling out NPs when we have to consider CNSs? And then, psych CNSs were the original, they no longer train that way, but the psych CNSs were the original mental health providers back in the day. Now you have to be an NP. We have to, so much complexity of who these people are to try and put it in a nice, neat table. I just don't think it can be done.
Is the thought, Lisa, that this committee at some point will address CNS in a similar manner?
Well, CNSs have not raised any questions or concerns CNPs have.
Right.
They
Yeah,
have a
totally
different
different.
scope
If
of
they were
practice, they
practicing
have
like
different
NPs, they're
certification
not
examinations.
CNSs.
So it's CNSs and at question.
A part of this work,
Mhm.
okay.
But they do, again, many of them, even though
No, I know,
the
but
traditional
they're not.
CNS that you're
Yeah.
thinking of, and I have those, the traditional CNS that is in the nursing world and doesn't bill typically, different than the CNS who is billing, doing face-to-face interactions
No,
with
I know,
patients.
and I know what
that's-
goes on out there,
yeah.
but that's not.
That's in their scope. That's in their training and that's in their scope. So it's, I think we have to not exclude them if we're trying, you're gonna see that more and more. These CNS programs don't have enough of the traditional CNS roles, and so many of them are looking at jobs that are what you would call an NP. There's nothing in law that precludes a CNS from doing that type of work. They have an APRN license, they can prescribe, they can manage patients just like an NP. So I think we're ignoring the fact that they should be included if we're going to do this kind of rule and model.
If I could make a recommendation that perhaps maybe we save the CNS conversation then for another
Yeah.
time,
Just
so
to
that
do a
we don't,
portfolio.
Yes.
because they are, from what I hear, very different from a scope of practice, educational. If we could maybe just focus on the APRNs.
Well, APRN,
The
CNS.
NPs, excuse me, the NPs.
Yeah, I
Yeah.
agree.
It's complicated enough.
It's complicated enough.
But
As it
again,
is.
as an employer, I have those people. I have those people, and
Sure.
if you're gonna tell me as the employer, you know, academics different, so you're training them, but then I have them in the real world,
Yeah.
and they're functioning, and then you're making an algorithm, I can't slot them in, and that's when you will get questions. I'm trying to be proactive here, so you're not missing the boat on what's really going on out there. There's
I think
not
if
a
we
lot
could-
of them, but you're gonna see more and more, because they can't get jobs in the traditional CNS role.
I think if perhaps we could get this model to reflect what we want, it might be easier
Yeah.
and pave the way for addressing that if it comes up for CNSs.
I think we should build it in, would be my recommendation, so that we don't have to go back.
I think if you were to do an IG for CNSs, it would be a separate IG. It would
Yes.
not
It
be
would look
folded
real
in.
different.
It would not be
It would
folded
look real
in
different.
as one. It's just not, from the way the board develops interpretive guidelines, may I continue? I'm so sorry.
Absolutely.
Sorry. Interpretive guidelines are in and of themselves not enforceable by the board. They are truly a guideline. And the whole idea of a guideline is to take existing statute and rule and apply that to particular situations. We've been doing that with registered nurse practice for a number of years now, and LPN practice. This is the first attempt at an interpretive guideline for APRN, specifically APRN CNP, simply because of the issues come up, and we've been asked to do it. Understanding that when the idea of administrative rules to clearly define terms was not what this committee was, the direction this committee wanted to go. So therefore, we took the statute, pulled in the national certification, which is referenced, and then provided you with this particular chart and NIG. If we were to do a CNS one, it would be different based upon that statute for the CNS and rules related. So, and then their certifications as well.
Lisa, with this draft, with this
Mhm.
chart,
Mhm.
when the lines were determined to end at a certain
Mhm.
point,
Mhm.
what was used
That-
to say this is where we think that line falls?
We went with what that particular certifying organization stated within its standards. Now, could it be more orange? Could it be more red? That is the human part of it.
Right.
That's arbitrary
Right.
in that sense. But it got as close as to what we, in reading versus, trying to objectively, subjectively apply that. That's where we were. The age ranges, I come back to when,
Yes.
with the, years ago, national certifications defined
Yeah.
the population by specific age.
Yeah.
Yeah.
They no longer do that.
I know.
And this reflects the general physiologic or developmental age.
Right.
And so that's reflected here, so.
I know, I was chair of the acute care, it used to be 18, and then
Mhm.
it came off the website, and none of us were really thrilled about that.
Mhm.
And they said, well, with it says in the APRN consensus model, which
Correct.
really doesn't.
And
So,
Yes.
in providing
issue.
the references, our goal or hope was that persons would refer back to the national certifying
Can we put the scope and
organizations.
standards of practice for all of these different areas as a reference on there, so people can note or at least refer to their own scope and standards of practice?
Within the
Reference
national
them?
certifying organization?
Yeah, like AACN has the scope and standards of practice for acute care, the primary care people have theirs, Peds has, NAP has got theirs. Psych, mental health has scopus, you know that. So I would definitely put that as a reference, their scope and standards of practice. I mean, they should know them, but I would definitely, because, you know, we go to, that's something that needs to be looked at.
Is there anything that this committee would find more helpful with this diagram? That
I don't know
would
about,
better.
I mean, what's written here is pretty good. And then if we refer them back to their own scope and what are they doing there? Scoping standards of practice, I think would be very helpful also. I mean, what qualifies this individual to care for this patient? That's the first thing the lawyers of risk management ask, having worked with all of them. And it's going to go back to their certification scope, formal education, scope and standards of practice, and education within that field.
I don't know if there's, I can't think off my head what would be more helpful. Like, I agree that the written language here is much more helpful than this chart.
It's clear.
The visual is very, it tends to try to draw a line where there is no line, right? But it doesn't. It makes it even more vague of understanding where that is. And I think having it as written language that, and I agree with Chris that, you know, giving reference, including those scope of practices and things in the written language would be helpful. There's a couple of things on here that I thought were interesting that I just want to comment on. Can I?
Absolutely.
So I think it's interesting that if you compare the two acute populations here, so for example, pediatrics and adult gerontology acute, how their level of where they can treat is very different, where so pediatrics starts in the orange and adult acute care starts yellow. So I think that's kind of interesting and confusing. And then keeping in mind too that all of the scope of practice put out by NOM for the competencies, I should say, not scope of practices, the competencies by NOM all include wellness and the care of a chronic condition. And I think it's interesting that in this one, the acute care don't start until the yellow, but wellness care and chronic conditions is included in the adult gerontology acute competencies. I'm unsure about the pediatrics. I'm not sure. I don't teach in the pediatric program, so I don't know the answer to that, but I should have pulled that and looked. So I think that's interesting that it kind of stops there, because the way that I see it is the acute care certification gives above and beyond into that critical realm, but includes within their
across the line,
across
the continuum of care
For chronic disease management.
Right. So, for example, if you're working in a cardiology office, you may see a patient in an outpatient cardiology office as an acute care nurse practitioner.
Right.
You may see a patient who is not maybe have an angina, but not an acute MI. But
No
that's a
exacerbation.
chronic condition.
Right.
And you might very well be managing their hypertension, their hyperlipidemia, their diabetes. For example, and I can think of one particular nurse practitioner I know that works in a heart failure clinic. She is basically that person's primary care provider in that heart failure clinic, because that's the only place they go for treatment. So she treats their diabetes, she treats their hypertension, their hyperlipidemia,
It's
their
about the
sinus
continuum
infection.
of care.
So
But
that
do you
could
remi-
be acute care.
You remind me that NOF, another reference here is that NOF has got great white papers on acute versus primary for pediatrics. I know I brought all this stuff up years ago. Yeah, exactly. That is a good reference, and then they have just a white paper that's only like couple of pages long, where they defined primary versus acute for peds. Peds has got a great article.
Yeah.
Peds and and adults, so I think those are all good references, and we can send them to you. I know I brought that up towards the beginning.
You have, yeah, I remember.
Yeah.
Sandy, you have a comment.
So there's a lot of good documents that are already out there.
So Jody, in your scenario, is that an acute care NP or a primary care NP?
In a heart failure clinic?
Yeah.
In my opinion, it's an acute care NP.
But they're managing.
They're managing a chronic complex patient
Right.
that could be potentially unstable.
You know, I think.
Because I believe that an acute care NP is not just practicing in the critical care unit.
Right.
Because they are formally educated
Right, I understand.
and certified to treat from wellness to critical. So in my opinion, that it's just a step above.
Right.
There's just more that you can do because you are educated in the care of critical care.
So in your opinion, an acute care can do anything?
No.
No. I mean,
I'm
we
not
don't
saying,
do
we're not talking about working in
internal medicine or
talking
family
about working in
practice or women's health or anything along those lines.
Right.
But what you're describing is what my internal medicine NPs do. They do all that, so.
Jody, let me, I guess, because I think I know where, Sandy, you might be going, but let me ask you this question. Could an FNP work in that same heart failure clinic up to a point of exacerbation that would result in end organ failure
yes.
or death? Okay.
So you can
I mean,
use
class
either.
1, class 2 heart failures, but when you're looking at 3 and 4 and along those lines, they're not, I don't think so.
I can speak from the way that our students are educated at my institution. In my opinion, personal opinion, I do believe that an FNP could care for a patient in a heart failure clinic.
Yeah.
Okay, but in the way they are educated at my particular institution, I would have to agree with Chris that when it becomes a stage 3 or stage 4 heart failure, they are not educated, formally educated, to care for those patients. They do not have the didactic or the clinical experience, because the way that the FNPs and the primary care NPs are educated at my institution, they are only allotted so many hours in a specialty clinic. And it may be in a heart failure clinic, but it's a very limited amount of hours versus what they have to have for certification. Maybe 60 to 90 to 100 hours out of their 700 that they need, versus an acute care NP who has 500 hours to sit for certification. All of those are spent caring for, they're not all spent in the critical care, in the NISICU, the SICU, the MICU, the CVICU. They are spent in outpatient cardiology, heart failure clinics, nephrology, urology, all caring for well and acute patients. That's all I can speak to, but I can tell you that the competencies in NOP does state that they're able to care across from wellness to preventive care to critical care.
And the scope of students of practice.
So I don't think they can do anything, but I think that it is a very, again, it's gray, and this, I think it leaves out that piece of it. And I don't want to be exclusionary, nor do I want to be proactive to one group or the other, but I think it's something that needs to be brought up.
I think it's not black and white.
I'm sorry. No, that's
sorry.
okay. Sandy has her hand up, and then I know Lisa has.
So, you know, in your model, everyone should be, why be a primary care NP? You should just go and get, because you're saying that the acute care NP can do anything. Not women's health.
I'm not saying that, Sandy. I think
you're
on.
like.
Well, I'm sorry that you're taking that.
The logical conclusion to your argument, then, you're not saying it, but the logic in what you're saying is that person can do.
No.
But I also said that an acute care NP should not be working in a primary care office. Can they work as a hospitalist? Absolutely. But should they be working in an outpatient primary care office? No.
Family practice, no.
How about
Internal medicine,
a real
no.
sick population like my population? You know, we're mostly 75% Medicaid.
But I think you
Medicare.
can make the other logical. I think you're uncharacterizing what I'm saying, first of all. But I think that you can also make the argument that if an acute care NP should not be working, I think it's, you have to think, I'm not sure why you're taking such offense to that, because I'm not saying that that everybody should be an acute care nurse practitioner, because not everybody wants to work with hemodynamically unstable patients.
But it
There's a
gives you more
reason why
latitude.
everyone picks a certain specialty, but at the same time, you can't say that an F&P can do everything as well because they are trained after their formal education. There has to be some standard. Like an acute care NP should not be working in a primary care internal medicine office, okay? Where an FNP should not be working in critical care. It's just different ends of the spectrum. One's down here and one's up here. But from the way this chart looks, I think that acute care NPs can care for wellness and preventive, and it leaves that out of here. But I do not believe that an FNP is educated from a formal education or within their scope or within their competencies as set forth by all the national organizations to be caring for critical care.
And then I would go beyond that, and trying to get away from acute care, is that if you look at the FNPs that come out and think they can do psychotherapy, and this is what we're seeing, okay? And taking care of these really complicated psych patients of which they have no formal education in. And even if you went for a course after that, is that really in your scope of practice? I don't think so. So I think it's more than just acute versus primary.
Yes. That's just where the focus is.
That's where the focus has been here, but I just think we're dealing with a lot more. And so a lot of the cases that are going on now have to deal with psych, not just acute care, but with psych.
So Lisa had a comment.
Oh, I'm always looking for changes, additions, whatever needs to be for this. Based upon what I'm hearing, what would you think about removing the graph chart and simply referring persons back to their national certifying organizations and its stated scopes and standards pertaining to that particular certification?
And some of these other documents of these organizations that have already worked this out. Yeah.
Yeah.
Yes.
The board, I mean, we can certainly, reference them since it talks about in our statute, practicing consistent with. We cannot, it's just difficult in the sense for us to keep, to republish other associations' information, which may change or be altered over time.
No, I mean,
as well,
you have the links in the back of the document, so that if it's just a matter of adding on additional references.
Oh, the links and so forth.
Yeah, that's what I mean. It's just to put it in as links. So the scope and standards of practice, and we can send you the links for, you probably have these, for those documents. And then some of the white papers that have been produced.
I think I would prefer, this is just my preference, and I don't know if we have to make a motion on this or not, but I think I like the idea of referring back to the scope of practice for the certifying bodies. I think once we start adding in all of these other organizations, it will not offer any more additional clarity. I think it'll cause additional confusion. These bodies are supposed to counsel, right, our certifying bodies to some extent. And so I like the idea of referring back to the scope of practice for their national certifications.
We always do that.
Right.
I tend to second what Pete was saying. And as for the graphs, I think in themselves they're actually helpful for the quick glance. I think people are reading way too much into this and trying to make these graphs definitive. If it's a quick reference for people who may not know, who may be curious to know, and of that self, it's a quick, easy reference to point out who may be appropriate to care. But in terms of what Pete was saying, I think it's completely spot on. I think us trying to take charge with rewriting these is way beyond what we're supposed to be doing here, and referring to this already predefined scopes that are already established. Would make a lot more sense.
And I
agree.
I think we're going to have to just learn to live in the gray.
Yeah.
And be able to say, be able to defend ourselves, right? That I practice according to my scope of practice. This is this is my reference, right?
Right.
Very similar to why we write off-label meds. We refer to something that's very valid. So I also like the idea of keeping the graphs because it's a nice visual. It's easy to just glance and say,
Right,
okay.
and I think you have to keep in mind, the reason I brought it up is just because I thought it was kind of, at first glance, very confusing.
Yeah.
And it is gray, but like you said, we live in the gray. And keeping in mind that none of this is law or statute, okay? It's not enforceable. I do agree with both of you that referring back to the scope of practice is the best, probably, approach. In addition, and maybe a statement that says, this is not, it's a guideline. Maybe some people in the public don't understand the difference between guideline and statute, that this is not enforceable. And I think it comes down to employers understanding what scope of practice is, and I don't think it makes much sense for the board to limit beyond much more than that.
Mm-hmm. Sandy, you had your hand
So
up.
a couple of comments. So is the purpose of this committee just to advise the board of what we think of these? Okay. And then my understanding from our last meeting that there would be an open discussion and I know OAPN, because we have their letter, must have gotten this. And how much more discussion will happen before something like this would be finalized?
So,
I guess it's up to the committee. Okay. I think it would be, well.
So from my perspective, so the academics may not understand what this would cost to someone like me who fields these calls all the time. So I'm the one who they say, whoa, what's this, and I would be calling the board, as I have many times, to say, please clarify. So here's my gray example. That's what I would be bringing a lot to the board. So to me, the broader we would make something like this, the better when you actually have to use it in practice. Another comment on this is the neonatal, and I know Erin is a neonatal NP, and I've talked to my neonatal NPs, and they absolutely say they are not primary care. So this graph is totally erroneous, in my opinion, because this looks like I could hire a neonatal NP from birth to age 2. I would never put a neonatal NP in a pediatric clinic to see 2 and under. Never. That is out of their scope to do well child in up to age 2. And they agree. When I talked to my group I talked to a few of them, their lead, that is not what they see.
So I know Lisa has a comment, but then I would also remind everyone that this is not setting, this is population. So while they may be seen in a clinic, it may not be for a well child, it might be for other health complications. Because Sandy, I completely understand what you're saying, but I would, myself personally as a nurse leader, I have FNPs that round in the critical care setting, not to manage the critical care aspect, but they're either following peripherally or they're managing a stable neuro patient, stable heart, but they're not managing the pressors, the vents, anything like that. So I guess I just want to remind everyone of that as well. And then Lisa had a comment.
No, the age and so forth, that was taken from NCCs, from their standards. So
I think she's talking about the green to
The
red.
specific neonatal right here.
So there's no line that they're not caring. To me, green is primary care.
and it's their.
Oh, and
But
see,
it's all interpretive,
yeah. And so when I look at those guidelines, I look at the green to the red as the severity of illness,
Okay.
not primary care to old
Right.
age.
If I was
Correct.
a neonatal NP,
So
looking
that
at this
usual state of
guideline,
health is
sorry,
sorry.
if I was a neonatal NP, and maybe didn't have a strong director, and sure, I can see up to age 2. I'll see those kids in your peds clinic after they're discharged from the NICU. So I think that one in particular is misleading. There's no line, so I really do take issue with that one.
So maybe you take usual health versus critical health out and you put severity of illness.
Yeah, That might be
and
even.
then you take out, I mean, but I don't know that it's gonna change the,
Or maybe we go back to the original thing about getting rid of the graph, because I don't, this part here, Sandy, shouldn't give you, I don't see anything that would give you an issue in what's written here. I mean, it's pretty global. I
What's
mean,
written
it's-
here, the only issue now that
Which one do you-
OAPN has brought it up is that definition of critical care, which I originally liked because those patients sound so sick. Maybe we remove the fact that it's from CMS, because I think that's OAPN's point, is that because it's from CMS, and if I bill a level 5, which I can, I can get it, I had a sick
Anybody
baby a
can.
couple weeks ago. And of course, I get them to the intensive care, right? But I can bill at that level. Would there be a misunderstanding because we're citing CMS? So maybe we use WHO or something that's not aligned with an insurance payment.
Or at the beginning of the scope of standards of practice for acute care, there's a paragraph there that really speaks to that, about, and it describes it right in our statement, the orange document, right in that very first paragraph.
yeah.
My friend has it memorized, I don't. So, that's something to look at. I didn't bring any of that with me.
I would encourage everyone to use, and again, maybe Lisa, this is a recommendation, but changing it from usual health to critical to more of a severity of illness scale.
Just take out that paragraph.
So,
If you take out that
I do like the
paragraph.
idea of the chart, but I think again, there has to be some statement that says, this is not,
yeah.
Oh,
it's gray,
interpretive
it's
value.
not
it's
black
gray.
or white,
This is
whatever
not-
that statement
This
is.
is not definitive.
This is, this is just for reference, this is just for somebody to look at and say, oh, okay, well, I'm an FNP, I shouldn't be working in critical care, I'm an acute care NP, I shouldn't be working in primary care.
And refer me back
And
to my
referring,
scope and
making a
practice.
statement that says you
Yes.
always need to make sure that you're referring back to your.
Your scope and standards of practice.
Right.
Easy peasy.
Right. Sandy?
I'm raising my hand.
You're fine.
They're not. So, I just want to point out OAPN's, in their recommendation for the interpretive guidelines. So I don't know if everyone has read this. I've read this kind of backwards and forwards because this is our state organization representing clearly MPs. If we're going to say this is only for MPs, so they give a much more simplified guideline that I think we should consider. In this letter, they indicate that they don't like the graphs and find them too limiting and confusing. And this is our state organization saying this. I appreciate the people at the table, but I also appreciate that we have very limited scope. I certainly don't have the academic perspective. I am not an academician. I have the employer view for sure and a practicing MP view for 30 plus years. So I think we would be remiss not to take these recommendations extremely seriously from a group that fields all these all the time, where most of us don't feel these types of things. I only feel a lot of organizations call me, but I have 250 APRNs that I talk to. But other organizations do contact me because of my work in the city. So this document is critical to review and to put forward as something that the board needs to very seriously consider.
Any comments?
I have a comment. So I've read this, thank you, OAAPN, this is really, really good letter, I thought, and it did bring a lot of things to my mind that I hadn't necessarily thought of when I looked at the board statement initially. So I looked at this first, and then I looked at the letter, and also the letter from Ohio State University. So, as this is my personal opinion, as I am also a practicing NP, I practice full-time. I'm also in the employment of other NPs within my organization. So I think I can speak from this again, but my one problem with the interpretive guideline is the one statement where scope of clinical practice for APRNs may be determined by the APRN's national certification, formal education, and clinical experience. That's that one statement, the clinical experience, is the one thing that I sort of, because what does that mean? Does that mean if you are a women's health nurse practitioner and you go out and you get a job in cardiology and you were trained that you should be able to care for cardiac patients? Which I think it's very unlikely that's going to happen. Or if you're a women's health NP and you want to work in the emergency room. I really struggle with this clinical experience, and I do as from an employer standpoint with the 22 NPs that I'm in charge of, that I would argue that with my APRNs, that yes, you are, but you are taught within your scope, and you have to first be hired within your scope and then clinically trained within your scope.
Chris?
I would second that, and the other thing that I don't agree with is this residency program, and these residency programs and fellowships are not designed to increase scope of practice, all right? So I think if you go with the national definition, I'm okay with, you know, the other stuff. It's based on nationally vetted competencies, formal graduate education, and certification. I mean, and if we look at our laws that were passed out here, I mean, since scope of practice is a legal definition, that's fine. And we already have that someplace in this interpretive guideline, I thought, all right? So in the clinical, I mean, a lot of people say, well, I was a staff nurse. Well, staff nurse doesn't qualify you to be a nurse practitioner, and that's this clinical experience thing is global, and a lot of people are taking it from that perspective, and that's just not the case. So I don't agree with the residency program, and then the same thing that you said about the clinical experience.
I just have one more comment, and then the last statement that clinical scope of practice may be further delineated by the employing institution or organization. Absolutely, in my opinion, no. It is not the job of the employer or the credentialing committee to be determining what scope of practice is by population-based certification. They can narrow it, but they can't expand it.
So this is not correct.
I feel like I'm the Debbie Downer of the group. Sorry.
No, I mean, you know, it's nice to have these things, but I think that we need to look at this, you know, and not just take it for.
Sandy?
Thanks. You keep saying Sandy because I'm the only one raising my hand.
Oh, no, I raised my hand. I have you know I raised my hand.
On the record, it's going to be Sandy, Sandy, Sandy. So I think this would be a great time to read Dr. Melnick's letter, too, as I requested, if that would be okay with the Vice Chair.
You want to read it?
I would love to.
Go right ahead.
Okay. So this was addressed on February 22nd, 2019 to Erin Keels as the chair of this group. It said, Dear Erin, I am writing to address the APRN Advisory Board on your discussion for APRN scope of practice and education. We at the Ohio State University College of Nursing would like to see this definition as broad as possible so we can accommodate the many opportunities that will develop for APRNs in the near and distant future. Some of our faculty drafted a statement, and the specialty program directors for all of our APRN programs, which includes adult gerontology, primary care, and adult acute care, family, peds, primary care, pediatric acute care, neonatal, women's health, psychiatric mental health nurse practitioner, adult gerontology, clinical nurse specialist, and nurse midwifery are all in agreement with the following statement. Scope of practice determination for APRN. Scope of clinical practice for advanced practice registered nurses may be determined by the nurse's national certification, formal education, and clinical experience as an APRN. For the purpose of this determination, formal education may be defined as a degree granting APRN graduate program, an APRN residency program, continuing education as defined in OAC 4723-14-5, or documented practice experience as an APRN. Clinical scope of practice may be further delineated by the employing institution or organization. We hope that the advisory board will give this statement strong consideration as we all wish to move the practice of APRNs forward in our state. Evidence indicates that the need for the services of APRNs is critical if we wish to move Ohio forward in becoming a more healthy state. Please contact me or Margaret Graham if you have questions regarding this request. Warm regards, Bernadette Melnick, who's the Vice President of Health Promotion, University Chief Wellness Officer, Dean and Professor, College of Nursing, Professor of Pediatrics and Psychiatry, College of Medicine, Executive Director of the Helene Wold Health Trust National Institute for Evidence-Based Practice at The Ohio State University. So, again, I think there, and if you know Dr. Melnick, she's a rock star. And, oh, it's also it's also Dr. Graham on the second page, so it's Dr. Melnick and Dr. Graham. Dr. Melnick came from Arizona State. She is well published in so many things. I mean, I don't know of anyone who's more famous than her in the nursing world, actually. So, you know, her advisement is critical to these discussions, as is OAAPM.
Go ahead.
I tend to agree. I have an issue with the clinical experience piece because you can't really standardize or validate that across the board, whereas certification and education is already standardized. The clinical experience piece could relate to anything from as simple as on-the-job training up to the things you see used. So it's
And then she says residency. It's not true.
yeah, the residency and the fellowship concept. Fellowships and residents, whatever you want to call them. I think the original intent was to refine a certain aspect of expertise that fell within the scope of practice,
Right.
not to
Exactly.
expand your practice.
Right.
And I think
So
it's
there's wrong information in here, and Margaret's on it.
Sandy.
I think the point of this is that, you know, when you're talking about a definition of scope, this leads into the gray areas of the clinical experience as your own admission that you can't teach everything in the academic program. Absolutely. So if you're going to say that, then you have to allow for all these other experiences that absolutely make a strong NP. Absolutely make the strong NP. Not when they come out of school, I can tell you, many of them are green as can be and cannot step in and function without my total support with programs of transition to practice and other things, especially in primary care.
So I just want to say again, I appreciate your comment, Sandy, but I think you're uncharacterizing what I said once again. And I want to clarify that when I say that you can't teach everything in a formal education program, which is why there are residency programs and things like that to further delineate and allow somebody to specialize and sort of form their craft in their specialization. But that does not mean, for the same reasons that when we go back up for relicensure, that we don't have to have continuing education. But there are certain core competencies that are taught in your formal education that are very specific to each individual population or certification. So, for example, family nurse practitioners will take classes on the well care of a child and woman. They will take class, and an acute care nurse practitioner will not take those didactic courses, nor will they have clinical training in those competencies. And an FNP during their formal education will not have education in, for example, whatever the course may be called, in acute vent management, line placements, those type of critical management type didactic courses. So you can't teach everything, but most academic programs, according to NOF, the way that we are credentialed is that we must teach across the board primary care for all of the students in the 3 Ps. And then as they divide, that's when they take their specialty courses. So when I say that you can't teach everything in an academic course, I'm talking about certain procedures or, you know, you can't try to take something I said and put it in a pinhole and keep bringing up that from my own mouth I said that you can't teach everything, because I'm not speaking that, I'm speaking to very specific things. So there is some on-the-job training, but that on-the-job training and the continuing education must occur within the scope. And I believe that this statement does not, it's saying that you can get that education outside of your certification or your formal education. It can come from a residency program, or it can come from a CEU or on-the-job training, and I just disagree with that.
So, sorry.
Go ahead, let Chris go.
Yeah, and I would echo that, and and we've already discussed the fact that residency programs, fellowships don't qualify. You're getting training. The students go to their primary care fellowship, or they go to acute care fellowship to learn. So you're getting educated within your scope of practice and your foundational training. I agree with the clinical, the continuing education needs to be within your scope of practice, and at least they have formal education, degree granting, and your certification is missing from this. And clinical practice is not delineated by an employing institution or organization. I mean, that says that I can come in and deliver babies. I mean, this is not correct information that's in this letter. It's just not. I mean, Melnick or not Melnick, there's a lot of other leaders throughout NOF and other people nationally and internationally that I know disagree with this letter.
Sandy.
So one of the problems, and I'm going to make a recommendation in a second. So one of the problems at this table, and I hate to bring this up, and I mean this with all due respect, is that we have 2 acute care NPs. There's just me, and Pete's kind of chairing, so it's a little harder for him, you know, representing primary care, you know, and James is for CRNAs. So this is a very lopsided discussion.
We're missing
So
two people.
well, I know, but, you know, again, and there's only 6% of APRNs in Ohio are acute care. So I feel like this has been a difficult discussion all along, where we don't have enough voices for the other side at the tables, particularly today. So my recommendation is that we bring in OAPN, who represents both acute care and primary care NPs, and have the discussion before we move any further with this. I'm not versed in the minutia of language of scope of practice. I mean, I read them all the time, but like you are, because you're in academia. So I want
And
those
practice.
experts, yeah, and practice, of course, in acute care. So I want to bring in OAPN at the next meeting as my recommendation for a good hour to discuss this, because we just keep rehashing these same things over and over.
I don't what's
But I thought we
your
already
specific issue? I don't, that's where I'm lost, because we agree on a lot of things.
Right.
I don't understand where you're at, and I want to understand, I really do. I don't understand what your issue is. I'm lost.
To make an informed, intelligent recommendation, it does not make sense to me to not have the state organization who wrote this letter that we're.
Right, but what's your,
So I
what's
want
the
them
issue?
to be here to defend those
Okay, I understand that, but what don't you like about, besides the critical care definition, I think we're all kind of agreeing on, what don't you like about the document that was put forth? Just the writing part, not the graphs. We all have issues with the graphs. What don't you like about the part of the 2 pages on the, I don't even know where it is now, the interpretive guideline? Help me understand what's the issue.
It's the, you know, clearly from my perspective, when I listen to both of you, acute care can, within their, you know, scope, can
That's
do
not what we
anything.
said.
So everyone should just train and do acute
No,
care.
Sandy,
Why
I'm
even
asking
bother?
you, what don't you like about this?
What I
About
don't
these
like
first
about
2
this
pages?
is it doesn't account for those gray areas, and it's too cut and dry. As I've been saying for 2 years, it's way too cut and dry. An NP is not ready to practice fully when they graduate from programs.
We know that.
Right.
We don't disagree with you on that,
So,
but
but you're saying that the only thing you want to look at, this is my problem, and this is what the board is trying to put down, the only thing you want to look at is their academic training. You're not considering anything else. You don't, the RN, I get the RN experience, that's it's very helpful though, absolutely. If they've been a strong RN and have years of an RN experience, they transition much more easily and competently than someone who hasn't been a nurse for very
So
long.
what else should be in this, that you think should be in this?
So I don't like the CMS definition, so I think we have
Right,
to look at
right.
that right away, because I think that
Okay.
is a very valid point, that
That's-
we could
okay.
put people on the spot
All
that
right.
would make it
So,
difficult for
but-
them.
Then what else don't you like? We referred everybody back to their scope and standards of practice.
I'm in that loop all the time, by the way. They'll say, I checked with my scope of practice, but I'm still not sure about this issue that
Right,
I'm facing, so they
understood,
call
but
me.
how-
So that's not always the final answer.
No,
You're
and I
making it
understand
sound
that,
like.
but how else could this, what else is missing, do you think, from this document? Help me understand.
I'm gonna jump in here real
Yeah,
quick.
I mean,
And
if you want me to go word by word.
No, you're
I think
okay.
we're over time.
we are over time, and what I wanted to ask the committee was, do we wanna continue working through? Do we wanna take a shortened break? Do we wanna break for lunch? We do have a couple of members that may not be able to stay till 2, which would mean we don't have a quorum at that point. Preference?
Let's break for like 15 minutes.
Break for 15 minutes? Perfect. So let's plan to return then at 12? How's that?
That sounds good.
Great.
No,
And we'll
I
pick
just-
up.
I was hoping to just
I
hear
would like to
what you
provide
have to
the
say, what
stenographer
you want
with
to
the
see
letter.
added
That's a
to
common
this.
practice.